Bismillahirrahmanirrahim and Assalamu alaikum, ladies and gentlemen. I welcome you all in this first plenary session of 19th Annual PES Conference. I am Dr. Uniba Syed. I am Assistant Professor of Endocrinology at Jinnah Hospital, Lahore, and I am Executive Member of Pakistan Endocrine Society. I'll be the moderator of this session. I request you to kindly either switch off your mobile phones or put them on the silent mode for the decorum of the program. So Pakistan Endocrine Society, the voice of clinical endocrinologists, advocating for the education and preventive medicine at the community level for the patients, organizations, and the public. A society committed to enhance the knowledge and management skills of its member in order to provide the highest quality of the patient care. It was founded back in 2003, and now we are having our 19th annual conference. And all this journey had the hard work and dedication of all the members throughout. So this society is presently headed by Dr. Ibrar Ahmed. He's consultant diabetologist and endocrinologist, presently the head of Department of Endocrine in Lady Reading Hospital, and the president of Pakistan Endocrine Society. I'll request him to kindly come on the stage for the formal inauguration of the conference. Dr. Ibrar.
Bismillahirrahmanirrahim. Assalamu alaikum. First of all, I welcome you all my speakers, all my chairs, all my delegates, and my corporate members of PES for this 19th annual conference. As you all know that we are meeting after 2 years, it was an uphill task to come and face-to-face meeting. But by the grace of Allah, we are here now in this meeting after 2 years. During this span of 2 years, it was a difficult period for all of us. We have lost our teachers, mentors, family members. I also lost my both parents. Most of us had the same phenomena. But with the grace of Allah, we are here, and now we can say that we are going to start our scientific activities. I am thankful to my organizing chair, Professor A.H. Ahmed, who is not here due to his mother illness. May Allah give her health, and his team to make such balanced state-of-art program. For the first time, we are expanding the time of scientific program and starting in evening. And with this program, I congratulate them for that. In the next 2 days, you can get some information regarding diabetes endocrine. I am thankful to Dr. Umar Yusuf Raja and his team. He's the organizing chair to organizing this beautiful conference for you. Regarding the journey of PES, which was started in 2001 with a few members, now we are growing in numbers. We have talented, energetic people working with us for the betterment of endocrine and diabetes. If you look at the graph, with the speed our executive members are getting in our society, and we are proud to say that in years to come, with this new blood in our society, we can go from our management aspect to preventive aspect, which is the need of our. Only diabetes, if we work for diabetes preventive care, it may change the dynamics in next 10 years. And we are taking this uphill task for us. And with my team, with my members, we can do it in future. I am thankful to Dr. Khurshid for leading this society in the difficult COVID era and keep this society vibrant. And I'm thankful to him. Since taking over this society in August 2021, what we have done, as Pakistan was opening, we have to kick off the scientific activities, educational activities. So first of all, we continue of the previous PES projects. We have to make them in run so that they should not be stopped. PAC PDP, National Diabetes Prevention Program, the inauguration, the work which was done on Journal of Pakistan Endocrine Societies, CMEs, formation of working groups, World Diabetes Day activity this time, which was seen all over Pakistan, is a story for us. Now we are signing some MOUs, and we have also launched our second edition of endocrine cases this year with the help of Dr. Fahim, Dr. Zareen, and Dr. Sumaira with us. If we talk about PAC-DPP, it is our flagship project for next 10 years. We upscale the activities, and I'm thankful to his teams, Dr. Arshid Hussain, Professor Basit, Professor H. Amir, Professor Khurshid, and his members, that we have an implementation document of PAC-DPP in hand now, and we are moving towards implementation. We have formed the committees, and inshallah, in years to come, we will be doing this. We will be doing MOUs with the government to involve us to further progress in prevention. On this forum today, I formally integrate the website of PAC-DPP so that we can reach them, we can do activities, and it is shown to the world, and we can involve others. So I formally integrate the website of PAC-DPP. This is due to the efforts of our executive members, Dr. Osama. Within a span of a week, we can able to do this, and we can formulate this PAC-DPP website. It will be a milestone for us, inshallah, in next 10 years. So the CME's activities all over Pakistan, my VPs, Dr. Ali Azhar, Dr. Khalid, Dr. Umar, Dr. Naeem, we done 10 CMEs within 3 months at different centers, difficult Pishin and Ziyarat was touched. And I congratulate the Balochistan chapter also. We have formed the working group of women's health, which was a dire need. Thanks to Farmiu for assisting us. And with PES logo or it was a major activity of September month, and PCOS awareness month was a success for PES. And we are looking forward for further programs, and we have chalked, and in next executive members meeting, we will be circulating that program of 2 years of this working group. World Diabetes Day, this time from roads to governor houses, from Khyber Pass to Karachi town. Everything we start activities, and it was, I think, these were the different activities our vice presidents had. And thanks to Dr. Ali Asghar VP Sindh, who did 43 activities. And I want to congratulate him for this major activity. And the other pharmas, CCL, GATS, Hilton, and Farmiu, these all ATCO, these all pharmas help us in each other. I just made 2 slides that how much investment and how much reach does these activities do. If the CCL project in this, we look all over Pakistan, awareness walks was done. So about 10 lakhs to 15 lakhs was invested, and about 1 lakh people were reached. They were aware. Regarding GATS Pharma, they done at public places, they screened some 3,690 patients, and of them 715 new diabetics were diagnosed, which was a major thing which we are facing. And they have done different media activities in which about 75,297 people were reached. And it was due to with calibration of pharma or corporate members and Pakistan Endocrine Society. So it is a success that if a small pharma industry of and Pakistan Endocrine Society can join hands and we can reach 2 lakhs people, what if we join hands with government? If we join hands with government, it is from this forum, I will be trying my best to form an MOU with my government so that this IDF data, which is circulated last week, we can do some preventive aspect and we can move this tide the other way. We are moving up and up, which is a matter of concern for us. I'm signing, my board of management will be signing memorandum MOUs with PharmEU for research purposes, for GERS and CCL for awareness, for Sanofi for this courses, inshallah, in coming months. So vision for tomorrow is more researches. My journal should be launched in a year span. Dr. Khurshid is looking after it. More research workshops is more educational activities for our members. The general access will be given to them. I am giving from this forum today up to date for my executive members, free access for 2 years, awareness program on different subjects and MOUs. These were my visions for tomorrow. For this vision, I want that to join new members. I am requesting that those members, those scientific members who want to be a part of this society, so they can register with themselves and fill the form which is present at Pakistan Endocrine Society booth. So, अगर हम सब काम करें तो अगर अपने seniors को ना याद करें, so that will be us. As my society is changing, most of us don't know what our seniors did. So I'm giving this tribute, this small tribute to my seniors from this forum. Bismillahirrahmanirrahim. First of all, I wish my seniors this accolade for their services for Pakistan Endocrine Society. As my society is transforming and is progressing in numbers day by day, I wish my regards to seniors and for juniors to follow the footsteps of their seniors. As a current president of Pakistan Endocrine Society, I want that my juniors should know what their seniors did for them.
The aim of the society was to propagate endocrine sciences, which were till then were not very well known in Pakistan. And I'm glad to note that with subsequent years and with our young enthusiastic members, the society has grown a lot, and now we are conducting sessions all over the year, and the society's chapters have now opened in every province of the country, and our young enthusiastic endocrinologists take the message of endocrinology to teach and propagate the general practitioners, other physicians in endocrine sciences.
One important struggle where we all participated and worked very hard was to get the recognition of CPSP for the fellowship training in diabetes and endocrinology so that it can be recognized as a separate subspecialty. It was a long struggle and all of us worked hard. It took many years, 8 to 10 years. And once the recognition came, now we know that this is a recognized subspecialty. The fellowship training is going on across the Pakistan, and there are so many new endocrinologists coming who are serving this important field in medicine, and which is the hottest topic for the metabolism, obesity, diabetes, and other endocrine problems.
इब्तदा में जो हमारी सबसे बड़ी मुश्किल और रुकावट थी वो ये थी कि एंडोक्रिनोलॉजी को हमें इंट्रोड्यूस करना था डॉक्टर बरादरी में और आवाम नास में. We took this challenge upon ourselves, held several mass media campaigns, including CMEs, seminars, public awareness sessions. We were engaging the channels, we were engaging the newspapers, and it all helped very well.
I was one of the leading founding members of the society, which was formed in 2003. And since the inception of the society, I have been involved in the development of the society. And the first and most foremost thing that was done by me was that I developed the curriculum for the College of Physician and Surgeon, and subsequently got it recognized by the College of Physician as a specialty. I had to, and we and my colleagues had to convince the president of Pakistan College of Physician and Surgeon to really accept endocrinology as a specialty, and soon our efforts were successful and he agreed to that, and finally this was the endocrine fellowship was started. It was started initially in Alpha, and then it was recognized by College of Physician and Surgeon, and that was the main thing that I contributed in addition to the founding the Pakistan Endocrine Society.
Future of Pakistan Endocrine Society is very bright. And I not only see that the people working within this country will be able to collaborate regionally through the platform of SAPNIS, but also they will be able to collaborate internationally with the International Society of Endocrinology and other endocrine organizations to help build a healthier and safer environment for people suffering from endocrine disorders.
So we started work on the guidelines, and we were able to deliver to the society and to the country and to the medical fraternity the first Pakistan Endocrine Society guidelines for diabetes and the management of diabetes in this part of the world.
When I took as a president, that was really difficult and challenging for me to elevate the society further. But with the blessings of Almighty Allah, I have introduced the Endocrine Fellows course in the Pakistan Endocrine Society. I have enhanced the grants, the travel grants for the fellows, that they will have better research and training opportunities abroad, that they will become more and more eligible for a better treatment of diabetes and other endocrine problems in Pakistan.
I see Pakistan Endocrine Society to be a prime, perfect focal point of all endocrinologists of Pakistan and a launchpad for dissemination of knowledge worldwide.
The last part, which is still in process, is start of the Journal of Pakistan Endocrine Society, JPES. We work with the registration and approval for this journal, and we are very close to getting the final approval process. Inshallah, we are hoping to bring out the very first copy of the Journal of Pakistan Endocrine Society in coming months.
हमारा नेशनल डायबिटीज प्रिवेंशन प्रोग्राम, आई विश कि ये एक सक्सेसफुल इवेंट हो और हम आगे चलकर इसकी वजह से गवर्नमेंट तक हम ये रसाई हासिल करें और हम डायबिटीज़ को के जो बहाव का जो तेज़ी का जो एपिडेमिक है उसको हम रोक सकें. In the end, I want to thank Dr. Ishfaq, Professor Akhtar Shirin, Dr. Tajammul, Dr. Samula and his team for me to helping in arranging everything. Have a nice, informative stay. I formally announce the conference to commence. Thank you.
Thank you, sir. Starting with the first plenary session, I take great honor to invite the worthy chairs for the session. Professor Saeed Mahir, Professor of Medicine and Consultant Endocrinologist. He's FCPS Medicine and also has Fellowship of Diabetes and Endocrine from Aga Khan University with clinical attachment at St. Bartholomew Hospital, UK, and was awarded as Best Fellow in Diabetes and Endocrine. He's also Fellow American College of Physicians and Fellow American College of Endocrinology. He remained the president of PES and General Secretary of American Association of Clinical Endocrinologists, Pakistan chapter. So I request you to kindly take your seat on the stage. As second chair will be Professor Dr. Khurshid Khan. He's the name which needs no introduction. He's MD, FACE, Diplomat American Board of Diabetes and Endocrinology, Diplomat American Board of Internal Medicine, past president of Pakistan Endocrine Society. Presently, he's the head of Department of Medicine and Endocrinology and Fatma Memorial Hospital, Lahore. So I request you to kindly take your seat on the stage. The first lecture will be by Dr. Richard Quinton. He's the consultant endocrinologist in the Newcastle University, United Kingdom. He's the special advisor committee member for diabetes and endocrinology and for the metabolic medicine. He's MA, MD, and FRCP. He's ex-regional training program director for endocrinology and diabetes. He received RAF Nobel Prize from University of Cambridge in 2021 and has special interest in clinical and genetic aspects of idiopathic hypogonadotrophic hypogonadism. And today he'll be taking the same topic. His topic would be late-onset hypogonadism, who should receive treatment.
Hello, my name is Richard Quinton. I'm an endocrinologist in Newcastle-upon-Tyne, UK. And I'm going to talk to you today about late-onset hypogonadism in men, and particularly who we should think about treating. With perspectives from guidance from the UK Society of Endocrinology, which should be published towards the early next year. I'm a clinical endocrinologist, although I do have some research interests, and I have a particular interest in male and female reproductive endocrinology and hypogonadism. So we want to live longer, but we all want to live well, and we don't want to have many years at the end of our lives which are frankly rubbish. So in relation to male aging and male hypogonadism, there are a lot of things in common. Anemia, sarcopenia, osteoporosis, sexual dysfunction, fatigue, obesity, and frailty. We know that if you have hypogonadism and you treat with testosterone, all those problems tend to get better. Of course, if you are an aging male and have those problems independent of having hypogonadism, then it's very unlikely that testosterone is going to help you. So it's important to be able to make the distinction. And we can see that some people in America, geriatric enthusiasts, may be taking testosterone use to extremes. The guy on the left is wondering why his testicles have shrunk, having overdosed on testosterone. So let's think about how hypogonadism presents across the male lifespan. We know that neonatally, you can present with disordered sexual differentiation or micropenis cryptorchidism. Later on, a delayed, absent, or arrested puberty. Then in adult life, gynecomastia, sexual dysfunction or infertility, vasomotor sweating and flushing, and as we get older, loss of secondary sexual characteristics as markers of hypogonadism. Of course, some of the men presenting late with premature osteoporosis, anemia, or myopathy developed hypogonadism later in life, but others actually had it much earlier in life, maybe even congenitally, just it was never diagnosed. So here's a man with Kalman syndrome, undiagnosed and untreated until age 68. And you can see the characteristic diagonal skin wrinkles of untreated hypogonadism. And he's our world record holder. He's the oldest man we've ever taken through puberty in our department. But we find ourselves taking a man through puberty above the age of 40 about once every 2 years or so. This is the science bit. I won't bore you with it too much, but I just want to stress that the control of gonadotropin releasing hormone secretion lies with the Candy neurons in the arcuate nucleus. And they take an awful lot of feedback. They take negative feedback from sex hormones, whether endogenous or exogenous, if you're abusing testosterone, and also from all kinds of inflammatory cytokines, prolactin, glucocorticoids, opiates, endorphins, general stress, adipokines, tending to shut the axis down. We know that adipose tissue, you need a minimum amount to have enough leptin to allow the system to work. But obviously, and exercise, too much exercise can also reduce leptin levels. But we also know that too much adipose tissue can cause problems like sleep apnea, and also further inflammatory cytokines. So we need to be in the Goldilocks zone for fat mass. We know that no matter what your illness is, physical, psychological, when you're ill, acutely or chronically, your LH-mediated testosterone levels fall. And that makes it very hard to distinguish non-gonadal illness from central hypogonadism because the biochemical profile looks the same. But we know that the biochemistry and the clinical features always resolve when the particular underlying disease is cured or remits. And for instance, we know that in men with so-called obesity-related hypogonadism, although I'm not totally sure if that is hypogonadism, probably non-gonadal illness, when in that situation, with weight loss or bariatric surgery, eugonadal status is restored. There's an interesting dimorphic relationship between testosterone and metabolic syndrome, type 2 diabetes, which is that higher testosterone levels in women and lower levels in men are associated with greater prevalence of metabolic syndrome in cross-sectional studies. And also longitudinal data show that having a low testosterone it shows in about a third of men with type 2 diabetes. But of course, it's also associated with future risk. Problem is that once you adjust for abdominal girth, these inverse relationships become much better, much weaker. In terms of measuring testosterone, really important to do it fasted. 3 key studies, all published in Clinical Endocrinology, showed around a 20% drop in LH-mediated testosterone with glucose or protein intake, whether you had type 2 diabetes, IGT, or normal, and that applied to both total or free testosterone. Always measure fasted levels, not just early morning. So how do we classify male hypogonadism? I think about primary testicular dysfunction as being the light bulb broken, and central hypogonadism as being the light switch is turned off. In the first case, your gonadotrophin levels make the diagnosis absolutely unequivocal. In the second case, can be difficult because actually the profile of central hypogonadism is indistinguishable biochemically from non-gonadal illness or afternoon or non-fasted venipuncture effect. So in this sense, clinical context is absolutely vital to make an accurate diagnosis. Really important study this, the European Male Aging Study, which showed that we always knew that testosterone levels fell with age, but we now know is that the overwhelming sort of factor behind this is accumulating non-gonadal comorbidities, obesity, inflammation, tending to suppress the axis. And actually, that's not really chronological. It's only chronological indirectly in the sense that as you get older, you accumulate more comorbidities. However, really interestingly, they found that 1 to 2% of older men have low T and high LH. So they genuinely had primary hypogonadism. And in this case, well, I will. This was equally related to chronological age and equally to comorbidities. And this could have been from EMAS. In fact, it's from the Chinese version, SPECT China, and it's kind of divided up into quadrants. So here's LH level, and here's testosterone level, and up here, your eugonadal men with normal LH and normal testosterone. Here we have the men with kind of low LH and low testosterone, and they're called secondary hypogonadism. But of course, in older men, that may well be a lot of it non-gonadal illness. Here are the men with primary hypogonadism. So they've got high LH and low testosterone, that's unequivocal. And then here we've got the men with so-called compensated hypogonadism, men with high LH and normal testosterone. But of course, that's a biochemical diagnosis. And you wonder, well, if your testosterone is low normal and your LH is high, and you have anemia, osteoporosis, infertility, or resistant sexual dysfunction, just how compensated is that? And also, there were no FSH data in the study, so other possibilities, you simply caught some LH peaks. Interestingly, in primary hypogonadism, nearly 40% of older men had type 2 diabetes. So that's a relative risk of around 3 compared to the background population. SPECT China is also interesting in that if amongst the really older men, you know, those who'd survived like Chairman Mao, Great Leap Forward, mass famine, tough as old boots, slim as whipcords, didn't get on Western diet, stayed skinny, they had no fall in testosterone as they got older. This was only seen in Chinese men up to middle age. So we can see how much of the effect is due to adoption of Western lifestyles. So how we define male hypogonadism? This is our society definition. So we don't like testosterone deficiency. We think that's a bit woolly and not really accurate. We say it's a clinical syndrome combining clinical features and laboratory evidence of impaired testosterone secretion and potentially also reduced fertility. It is possible to be hypogonadal and have normal fertility, but it's exceptionally rare and should be considered the exception rather than the rule. However, if you have primary male hypogonadism with high LH and low testosterone, to be honest, you can diagnose that off a single venipuncture, and to be honest, without any clinical correlation, unless the blood sample comes to the wrong person. And we also say that although the diagnosis of hypogonadism conventionally requires sexual symptoms, we feel that testosterone, particularly in older men, is just as important for men's general health as for sex and reproductive health. So the absence of sexual symptoms in an older man, we would not consider that to rule them out of having hypogonadism, if, for instance, they had osteoporosis or anemia, for instance. And so we think that hypogonadism should be really framed contextually in the context of one of the recognized clinical causes and whether the defect is testicular or central. Rather than saying, oh, he's hypogonadal. That's not really enough. I always suspect a diagnosis like that, which doesn't have enough context or detail in it. And to recognize clinical features of hypogonadism can be reproductive or they can be non-reproductive. And those can be physical, such as osteoporosis, fracture, vasomotor symptoms, anemia, or they can be psychological, loss of motivation, concentration, irritability, low mood, or body shame. So that's your clinical diagnosis. Now to the lab diagnosis. Always measure levels fasted before 11 a.m., preferably after a good night's sleep, and not during periods of intercurrent illness. The diagnosis of hypogonadism is supported by raised LH level, low bone density, anemia, or serum T below reference range on at least 2 separate occasions. When the LH isn't raised and central hypogonadism is suspected, need to do further investigations to exclude wider hypopituitarism, iron overloads, and potentially MR scanning, unless there is compelling evidence for non-gonadal illness. If someone's got a low testosterone and they've got like low pneumonia or heart failure, well, that's what you expect to see. There's no need to MRI the pituitary gland. Whether testosterone is borderline or inconsistent with clinical context, should measure SHBG level to allow calculation of free testosterone. And that correlates better with androgenicity, where the SHBG is at extremes of the reference range, but it adds no value when the SHBG is mid-range. There are problems with the free testosterone calculations. There are also problems with the SHBG assays. So this is not perfect and needs further work, particularly in our laboratories. So let's repeat. So late-onset hypogonadism, so this is the definition for the EMAS study. And they defined it based on association with sexual symptoms and low testosterone level. And those 3 symptoms were reduced desire for sex, low libido, fewer spontaneous erections, and erectile dysfunction. And they required at least 3 of these symptoms and total testosterone below 11 and free testosterone below 220 calculated. But of course, all our assays are a bit different, aren't they? So let's deconstruct it. Originally, it was deemed to be associated with aging-related comorbidities, particularly obesity. Symptoms of hypogonadism may be existing low serum testosterone, but after excluding classical causes of hypogonadism. And I think potentially there's a lot of non-gonadal illness in there, and I'm not sure that that original diagnosis necessarily holds water. But even by that relatively loose diagnosis, only 2% of men aged 40 plus fulfill criteria for late-onset hypogonadism. So I would say that real late-onset hypogonadism, this is the men with primary gonadal failure, the 1 to 2% with high LH from Leydig cell dysfunction, and I think that's probably where we should reserve the term for. So although the incidence of primary hypogonadism in men is low, about 0.2% a year, it increases equally with both chronological age and illness. And as I said, it's associated with 3-fold relative risk of type 2 diabetes, which is what you see exactly in Klinefelter syndrome and dystrophy mytonica. So there seems to be something about primary gonadal failure that predisposes you to type 2 diabetes. Or is it the other way around? Testosterone and erythropoiesis. We know that testosterone stimulates red cell production in the bone marrow, although how it does it isn't actually clear. And we know that if you're deficient testosterone, whether you're hypogonadal, a child or a female, you have lower hemoglobin and hematocrit. And if you abuse testosterone, like Lance Armstrong, you will end up venesecting yourself because of erythrocytosis polycythemia. What are the risks of having a high red cell count? Well, we know that for the Copenhagen study, the top 5 centiles for hematocrit had a 50% relative risk of MI compared to the middle 50 centiles. And in the Tromsø study, the top 20 centiles for hematocrit had a 50% increased risk of VTE and a 240% increased risk of unprovoked VTE compared with the bottom 40 centiles. Which is why when we monitor therapy, my priorities are always hemoglobin and hematocrit all the time. Serum testosterone, yes, other things being equal, try and keep it mid-range, but whatever you do not let the hemoglobin and hematocrit rise. Testosterone and bone health, obviously important in aging, and there's a couple of interesting trials here. So there's the bone trial, number 6 of the T trials. These were older, overweight men, high prevalence of metabolic syndrome and diabetes. Again, slightly unclear the extent to which they were truly hypogonadal or whether they had non-gonadal illness, but any other randomized to placebo or testosterone gel. So in these men, there was a 7% rise in spine trabecular volumetric bone density after 1 year of gel versus placebo, which is quite remarkable. The T-bone study, which is a sub-study, the T4DM study, these are slightly younger men, higher testosterone levels, many with normal testosterone levels. Again, they excluded primary hypogonadism. Again, I think that's a shame. We should have data on them as well. And these are men at risk of type 2 diabetes or having early type 2 diabetes. And the intervention was Nibido plus lifestyle or placebo plus lifestyle. And they showed a slightly smaller rise in spine trabecular density over a longer period. But again, these men were even less hypogonadal than the men in the bone trial. But that's pretty powerful effects on bone. And I was like a real life situation. This is a Kalman patient, one of my patients, puberty induced at age 57, just the testosterone, no bisphosphonates. And you see just the remarkable increase in his hip and spine bone density over a period of 10 years, just with testosterone treatment. So the anemia testosterone trial, which is part of the trial number 4 of the T trials. And what they found was that the older men they recruited, about 1/3 of them had unexplained anemia. And a similar number had anemia that they thought was explained. But it didn't really matter whether the anemia was explained or unexplained. When you gave testosterone, the red cell count, hemoglobin, hematocrit all rose very significantly. Which brings us to a little study that we did in Newcastle. This is the National Gallery in London. So this is a little child. That's the hemoglobin hematocrit of a typical child. This is Venus, and this is Mars, and his levels are much higher. And of course, that's because of testosterone. I do love the phallic lance there. So this, I think we've already seen. So our hypothesis, which was unrecognized primary hypogonadism, was a simple cause of anemia in older men admitted to hospital. So I did this 2 years ago, 2-3 years ago, when I was just doing medical duties. And so we simply looked at all the inpatients that came under me with pneumonia, heart failure, whatever. I looked at the men, looked at those with anemia, and characterized the anemia with hematinics, excluded those with GI bleeds, we then those who knew the anemia seemed to have no cause, we did an FSH level. And if the FSH level was raised, then we did the full gonadal hormone profile. And then, well, so here are the results. Nearly 200 patients, about 1/3 of them men, generally older, about half were anemic, and about half of them the anemia was unexplained. And of men with unexplained anemia, half of them had a raised FSH level. And most of these we diagnosed with hypogonadism, and started on testosterone needle every 16 weeks. In fact, 2 of them we rescued from the bone clinic where they were seen by geriatricians for osteoporosis. Obviously, we stopped at alendronic acid and put them on the appropriate treatment. These are the patient characteristics. Actually, this study was actually very prone to false negatives. Because we were so keen to avoid false positives, in fact, we were at high risk of having lots of false negatives. So we would miss men with central hypogonadism, we'd miss men without anemia, but still had hypogonadal. We'd miss men with hypogonadism and anemia, but who had abnormal hematinics or suspected GI bleed, and also men whose FSH was suppressed into the normal range due to non-gonadal illness. So essentially, primary hypogonadism is a remarkably common cause of unexplained anemia amongst older male medical inpatients, and it's a very easy biochemical diagnosis, and you can make it on an acute medical ward. And particularly the combination of anemia and osteoporosis is an absolute wallpaper match for male hypogonadism. So when you see older male patients on ferrous sulfate and alendronate, you think, let's screen them for hypogonadism instead, before we think about a bone marrow biopsy. Let's think about testosterone replacement with old age or disability. So important to emphasize that the overwhelming majority of older men maintain LH-mediated Leydig cell function lifelong. Therefore, chronic disease per se is no barrier to testosterone replacement, provided the diagnosis of hypogonadism is secure. And the older men potentially stand to gain a great deal in terms of underlying anemia, osteopenia, and frailty. And that having physical or mental disability should not be result in you being denied treatments that would otherwise be considered to be standard for those without disability. But obviously we need to make the correct diagnosis. So very easy if your patient's got a high LH, and you've got primary hypogonadism. But if you're thinking about central hypogonadism, this is only really a secure diagnosis when framed in the context of a recognized clinical syndrome, such as due to opiate analgesia or brain irradiation or iron overload, for instance. Other thing to think about is if you've got a high normal hemoglobin hematocrit or a normal sperm count, you're very, very unlikely to be hypogonadal. And particularly if you've got a high normal hemoglobin hematocrit, you're very likely to become polycythemic if you get given testosterone. However, if the diagnosis is correct and this patient doesn't have non-gonadal illness, then testosterone is safe, cheap, and effective, particularly so for bone and bone marrow health. So, who shouldn't get testosterone replacement? Well, the positive risks versus benefits of testosterone in male hypogonadism cannot be extrapolated to men whose low testosterone levels are due to age-related frailty or obesity-related frailty or non-gonadal illness. And also, if you've got active breast cancer, prostate cancer, if you're seeking to have children, or you've got erythrocytosis or uncontrolled obstructive sleep apnea or cardiac failure, then you should defer testosterone treatment. And really for obese men with kind of borderline low testosterone and low normal LH, we really emphasize the primacy of lifestyle change over testosterone replacement, unless there are compelling reasons, such as osteoporosis, anemia, reduced testis volume, or refractory sexual dysfunction that doesn't respond at all to Viagra. And although the T4S study showed a protection against developing type 2 diabetes with testosterone replacement in obese older men, with or without low testosterone, this was at the cost of what I would feel is an unacceptable rate of erythrocytosis and potentially risk of thrombosis. So where are we going to find hypogonadal men? Well, men with sexual dysfunction and fatigue, pediatric syndromes, they all grow up eventually. Childhood cancer survivors, more and more of them are growing up now. Those who had radiotherapy to brain or testes, or who had alkylated chemotherapy. Fertility clinics, turning up men with azoospermia. Testicular cancer survivors, even those who still have one testis in situ, that testis is often not normal with a degree of gonadal failure. And again, they're prone to metachronous cancers, so one may have to be removed, then another one many years later. Those who've had skull base or pituitary surgery or radiotherapy. And of course, Klinefelter syndrome, about 1 in 600 male neonates, many of them undiagnosed even in Western countries. Men with osteoporosis and fracture, and men with anemia and frailty. So some slightly controversial positions may be taken by our society. We're really saying that, to be honest, everybody who's got a diagnosis of hypogonadism should receive testosterone, provided the diagnosis is secure. no matter how old or whatever physical or mental disability. And if you have osteoporosis associated with hypogonadism, we believe that first-line treatment should be with testosterone. Although where your fracture risk is very high, or maybe you've already had a major fracture, it would be reasonable to also prescribe a bone-specific agent such as bisphosphonate. Also, we couldn't see any evidence that men with hypogonadism on testosterone were at any greater risk of prostate cancer than the general population. And therefore, as prostate screening isn't mandated for the general population, we couldn't really see why it was mandated for men on testosterone replacement. However, we need to remember that with prostate cancer risk, it varies a lot according to age, family history, and ethnicity, particularly Afro-Caribbeans. And that should be factored in your decision to whether to screen or not screen. So many thanks for your attention. And I'm open to questions now. Yes, I wish I could be there with you. Well, I will be there with you, but just not in person when we do our Q&A later. Thank you.
Thank you, Dr. Quinton. At the moment, he's live with us and will take any questions that you have. Sir.
Thank you very much. Thank you very much, Dr. Richard Quinton, for your excellent talk. You covered many clinical parameters after testosterone replacement therapy. Will you please put some light on cardiovascular events or safety after testosterone replacement therapy?
Yes, I could, but if I did, I'd have to kill you. So we do have data. We have submitted to, there's Dr. Ali Jawa there. Good to see you. Hi there. We do have data, and we've submitted to Lancet Diabetes and Endocrinology. Well, we'll have to wait and see. But I have to say, I'm not too worried. Some people describe the testosterone as being a miracle thing for diabetes. That's almost certainly not the case. Others are terrified it's going to make people have strokes. We know the FDA puts a warning out, and we know the European Medicines Agency does not put out a stroke warning. I think that what I've seen has been relatively reassuring. I'm not sure I can say more than that. Watch this space.
Thank you, sir. Is there any other questions that we have? So if there is no question, I'd like to thank Dr. Richard Quinton for taking out his precious time for us. Thank you, sir.
Thank you so much. Luckily, my patients haven't turned up for clinic this morning. And I recognize that room in the Serena Hotel. Hope to be there with you again one day. And just to say, our guidelines are now in press. They're published online in Clinical Endocrinology. All the very best to you. Godspeed.
Thank you, sir. For the next lecture, I'd like to invite Dr. Niaz Khan. He's MRCP CCST, consultant endocrinologist in Imperial College London Diabetes Center, UAE. He'll be speaking on diabetes and hypertriglyceridemia, a combination overlooked. Dr. Niaz.
Thank you very much to PES for inviting me, and I'm also grateful to A.H. Amar, who is not present, who first contacted me for this talk. It's a huge topic, but I'm supposed to cover it within 25 minutes, so I'll try my best to cover it, and especially for the trainees, to give them a few points to think about. To begin with, let's look at the global burden of cardiovascular disease. There are almost 18 million people who are dying from cardiovascular disease. And it's the #1 cause of deaths at the moment, has already taken cancer and respiratory diseases deaths, so combined together. And it accounts for almost 33% of deaths due to CVD worldwide. Now, another thing we need to know is that the cardiovascular death is actually happening in population which is considered to be low income or a middle income. So that's another pointer to us that we are being faced with this problems because of this low economy and so forth. Now, another contributor to this increased cardiovascular disease is rising prevalence of diabetes because of the rising obesity and so forth. As we know, diabetes increases the risk of cardiovascular disease by 2-fold, even the mortality by 1.5 to 2-fold. And the diabetics, on average, they lose around 10 years from their life expectancy. And despite all the advances, in the standard of care, statins and ACE and so forth, most patients with type 2 diabetes still are dying from cardiovascular disease. It's estimated almost 50% of our diabetics are dying from the premature cardiovascular disease. Now, we would immediately think of this increased cardiovascular disease is due to atherosclerosis, which is right. And we all know that atherosclerosis happens in the context of cholesterol. Atherosclerosis cannot happen without cholesterol being deposited within the blood vessel. Now, to understand this, that's just for the trainee one, so that I can take my lecture forward, is that the lipids which we consider as cholesterol and triglyceride, they are water insoluble. So they have to be ferried in the plasma through some kind of vehicle. And that vehicle is provided by the lipoprotein, a very important factor in the pathogenesis of atherosclerosis. Now it has got that core which protects the cholesterol and the cholesterol ester and the triglyceride within the core. And outside it has got phospholipids, and also it has got what is the most important thing is that apolipoprotein. Now, why I call it so important, apolipoprotein, which is on the surfaces, because it's like a biochemical key for this lipoprotein. It directs the lipoprotein to its wherever it wants to take it for its uptake by the appropriate receptors. It also directs the lipoprotein towards the appropriate enzyme for a degradation or whatever the function that enzyme has got it. And another important thing to note is that per lipoprotein, there is only one apoprotein, okay? And also to remember is that this lipoprotein, its size can increase or decrease depending on the content of mainly triglycerides. As the triglyceride go up, the lipoprotein swells up. And as the triglyceride go down, the lipoprotein becomes smaller and smaller. So that concept is very important to consider when we talk about the atherosclerosis. And also to remember is that the ApoB, which is the apoprotein, it's present in the VLDL and its other, the remnants of it, and also the LDL. So this is important to consider that the VLDL is the precursor of all the other atherogenic lipoproteins, including your LDL. So this is another important concept to remember, that the LDL, they generate from the VLDL. And the VLDL originally are very, very high in triglycerides. As you can see, 80% is triglyceride, 20% is cholesterol. And the LDL, on the other hand, is the reverse. It has got 20% triglyceride and 80 to 90%, sorry, 10 to 20% triglyceride and 90% cholesterol. So LDL is very rich in cholesterol. VLDL is very rich in triglycerides. So what's the significance of it? The significance of it is that the cholesterol, which is deposited in the blood vessel, you would think it has to come from the LDL, which is fine. I agree with it. But to bring the cholesterol to the blood vessels, it has to go through certain maneuvers. And that maneuvers are that lipoprotein, which is carrying the cholesterol, has to cross that blood vessels, that endothelium. it has to then be retained within the intima after the endothelium. And then after it's retained, it has to provoke an inflammatory reaction by having the monocytes, which gulp them, makes them form cells, and then degenerate to cause the atherosclerosis. So the important point why I took it such a long kind of introduction is that you need to remember that cholesterol deposition takes certain steps to come down to that final stages. And we all know the LDL, the lipoprotein, the low density lipoprotein, is well placed to carry out this function. Why? Because LDL is a small particle, as I showed you. So it can cross that blood vessels, the barrier of endothelium quite nicely. It also has got very high level of cholesterol. Therefore, it's well placed to cause atherosclerosis. And that's why we all tend to target the LDL cholesterol, because LDL cholesterol reduction will mean that we are reducing the atherosclerosis. And that's what we have shown in all the epidemiological and interventional studies, that lowering the LDL cholesterol leads to proportionate reduction in the cardiovascular events. For 1 millimole, you get the reduction of 22% in the cardiovascular events. And no matter where you start with regard to LDL, whether it's 5 or 4 or 3, as long as you get reduction, you will get exactly the same proportionate 22% reduction per millimole in the cardiovascular event. So that's very, very nice and well documented. But the problem is that despite having patients treated with statins, and statins reduce the LDL cholesterol by increasing the LDL receptors on the hepatocytes, we still have got patients suffering from the cardiovascular events, what we call it the residual risk. And this residual risk, despite the benefits of reducing LDL, remains as high as 85%. Okay, so that's important. So, and this residual cardiovascular events, despite being treated with statins, it still holds true if you look at our diabetic patients. These are all the studies done with the statins. Some were diabetics, some were non-diabetics. And when you compare the two, diabetics get the same benefit as non-diabetics, but their residual CV risk remains the same, just like any other non-diabetics. So our diabetics are also suffering from this residual cardiovascular risk. Now, you may say that is because in the earlier trial, we didn't get the LDL cholesterol down to a very nice low level, but that's not true either. Because if you look at the later studies, which is IMPROVE-IT and 4-year one, and also the recently the REDUCE-IT study, where you started with LDL very low as 67 to 92 milligrams. So you got the LDL cholesterol down to a very reasonable level. And despite it, you can see the residual cardiovascular risk at 3 years is 14.6%. It goes up with time to 28.3%. And more than 1/3 of the patients is still are getting cardiovascular events. This is despite getting the best LDL cholesterol. So what does that mean? Now, as I explained to you, the atherosclerosis is due to cholesterol being deposited. Now you got rid of, you got LDL to a reasonable level. So what is driving this now residual cardiovascular risk? So what is bringing now this extra cholesterol to the atherosclerotic, those plaques, causing the atherosclerotic plaques? So this is an important concept to remember, that there is something else is bringing now the cholesterol after you have done and dusted with LDL cholesterol. Now, if you remember my previous slides, the lipoprotein, the E1, the triglyceride rich one, which is the VLDL, it still has got that 20% of cholesterol. And when we measure triglyceride, It's a marker of the triglyceride-rich lipoprotein. So could it be that those VLDL particles containing cholesterol are now the next kind of vehicle for bringing cholesterol and depositing in the blood vessels? So the question is, high triglyceride is a marker of increased CV risk, which is a residual after LDL cholesterol control with statins. So can we rely on triglyceride as a risk measurement of those VLDL particles, which is probably atherogenic? I'm using the word probably atherogenic. So let's look at the nature's experiment. Now, this is the population-based studies where they looked at the Western kind of Europe and North American population, long surveys, population-based studies, and linked the high triglycerides versus the lower triglyceride to the risk of the cardiovascular events. And what they found is that the high triglycerides in the upper quintile actually poses an increased risk of almost 70% compared to the lower the triglyceride levels in this population, in the Western and the European population. Now, this is almost exactly matches what we saw in the Asian and Pacific population, where they also showed through the population studies that the high triglycerides, it is a risk marker for the incidence of cardiovascular events. And so the high triglycerides risk for the cardiovascular events in all population studies, whether you look at our population, Asian and Pacific regions, or the Western and the European population. So that was the population-based studies. What about in intervention studies where we put the patients on statins and then look at their residual risk? Now, this is the PROVE-IT study. PROVE-IT study was shortly, it was acute coronary syndrome. One arm was treated with pravastatin 40 milligram, one arm was treated with 80 milligram of atorvastatin. And what they showed is that in both arms, even on target is where LDL is below 70, so you reach your target of LDL, and then you looked at the subgroup analysis, patients who are on starting with after the LDL below 70 have a high triglyceride of more than 200 and below 200. And what they found is the people who have this high triglyceride after reaching target of LDL of 70 or below have increased risk of cardiovascular disease by almost 30%. So this is another evidence to us that there is some linkage between the high triglyceride and the future risk for cardiovascular disease, despite getting a very good LDL cholesterol below 70. What about the population-based studies, those who are on statins? And again, the same phenomenon is happening. The people in the high triglyceride, despite having LDL between 40 to 100, very nicely controlled on statins, people with high triglycerides, it links with the increased risk of the cardiovascular events. And you can see at the bottom, non-fatal MI, non-fatal stroke, whatever you look at, these are increased in people with high triglycerides. What about our diabetic patients? Now, this is a nice study which was done in 2019. It looked at the incidence of hypertriglyceridemia above 150 up to 500 among patients with type 2 diabetes. And they found it almost more than 40% of people, type 2 diabetics, again, well treated with using statins, have got increased triglyceride. And they did a kind of, complicated kind of, cardiovascular risk assessment in these patients. And what they found out was that these hypertriglyceridemic patients, 85.5% have a CV risk score of 7.5 or higher if hypertriglyceridemia is present. So hypertriglyceridemia equals your higher risk for atherosclerosis. So the point is that why is that hypertriglyceridemia is a risk for, I'm not saying it's a causation, but why is a risk for it? The reason is because triglycerides, the high triglyceride are a marker of triglyceride-rich lipoproteins. And these are VLDL and VLDL remnants and the chylomicrons, okay? Now, chylomicrons cannot cross the blood vessels because they are quite big. LDL safely can cross the blood vessel, go into intima and so forth. On the other hand, VLDL remnants, it can actually cross the endothelium. And another point about the VLDL remnants or the triglyceride-rich remnant is that they do not need any modification once they cross it, like LDL, where they need to be oxidized to attract the monocytes, macrophages, to take them up and convert them into a foam cells. Here, the remnants, the VLDL remnants, they do not require any modification. The monocytes can sense them, can take them, gallop them, and make them foam cells. So in a way, VLDL remnants are more atherogenic compared to LDL. But because the LDL particles are more in the blood, so that's why they impose more atherogenic risk. Now, this is another very good nature's experiment, and just I wanted to just highlight a few things about it. Why I call it it's a nature's experiment, because the researchers, they took patients who have naturally low triglycerides through the genetic kind of alleles which are causing the low triglyceride, and compared it with another genetic variant where they have got naturally low LDL cholesterol. Okay, so the two groups, nature's experiment, both are having, one is having low triglyceride, one low LDL cholesterol. Amazingly, both are having low cardiovascular risk. One is through the reduction of ApoB particles, which are rich in triglyceride. The other one is having low cardiovascular risk because of the LDL particles, okay? Meaning the two are actually able to cause atherosclerosis equally, okay? There is no difference between the ApoB containing LDL particles or ApoB containing VLDL or its remnants one. So this is the nature's experiment. What about our type 2 diabetics? Type 2 diabetics, as we know, we call it a diabetic dyslipidemia because the diabetic dyslipidemia is characterized by high triglycerides combined with low HDL, and this LDL, what we call it, is small, dense, low LDL particles. And to explain this, because diabetic dyslipidemia is a peculiar kind of dyslipidemia which predisposes patients to atherosclerosis. And you and me, when we see this triglycerides, a high triglyceride, it means something. We need to dig deep into it. And why I'm saying is because if you look at this pathophysiology of this diabetic lipidemia, it will explain a lot of things, this increased risk of cardiovascular disease. Now, this happens because, to begin with, from the insulin resistance. This is the key thing from the, So this is the insulin resistance is the key underlying factor, which leads to increased lipolysis. Increased lipolysis bombards the liver with free fatty acids. And then the liver has got no option but to convert them into VLDL. Plus, it also, in the presence of insulin resistance, it has got de novo synthesis of fatty acids. And therefore, the liver gives out a lot of this VLDL particles. Okay, increased synthesis of VLDL. Now, what happens when there is increased level of VLDL? You get a high triglyceride. So high triglyceride is a marker of VLDL, but it's not like this. There is another phenomenon is happening at the same time, that the high triglyceride, it upregulates an important enzyme known as CETP, cholesterol ester transfer protein. And this makes a lot of changes. Oh, sorry, give me another 5 minutes, please. Yeah, it gives another lot of changes within the LDL. What it does is it takes cholesterol from the LDL and it gives the triglycerides. So the LDL becomes triglyceride rich, is more susceptible to lipolysis, and therefore it becomes small. When it becomes small, it is more oxidizable. It can cross even more freely into the blood vessels. On the other hand, also the VLDL and with its associated CETP upregulation, we get HDL enriched now with triglycerides. It also becomes susceptible to lipolysis. You get low HDL. So I'll just skip this because of this. So how can we then, how can we measure then all those lipoprotein particles which have the potential to cause atherosclerosis? Because all the lipoproteins, including VLDL, intermediate, they all carry cholesterol, and it's the cholesterol which is deposited. So by having the LDL cholesterol, you are only looking at one aspect of atherosclerosis, LDL cholesterol. So what can we do? The best thing is to do what we call it that non-HDL, total cholesterol minus HDL minus, and you get non-HDL. The beauty of non-HDL is that now you are calculating all the cholesterol present in the blood, be it LDL cholesterol or be in VLDL remnants and so forth. So just another thing is that what about any cardiovascular intervention studies where you have targeted the triglycerides? Have you shown any cardiovascular improvement or not? Fenofibrate, yes, it is a good agent because it does exactly what we have seen in diabetes, opposite to diabetic dyslipidemia. It makes the LDL big, fluffy, raises HDL, reduces the triglyceride, and therefore you think in diabetic patients, if you put them, you will get some cardiovascular benefits. Now, a CART lipid was exactly that trial where patients on statins, they put them on fenofibrate. The overall trial results were negative. So I'm showing you the subgroup analysis for one reason. Because in the trial one, unfortunately, the baseline triglyceride wasn't that great. So they didn't really pick that juicy kind of, the high kind of VLDL particles. But if you then do the subgroup analysis, the patients who have got the high triglyceride with low HDL, these patients, they do best among the patients who are put on fenofibrate. Just telling you that the best patients to pick up for treating with fenofibrate is the patients who have got high triglyceride. These are the patients who do better, almost about 40% reduction in their cardiovascular events. Sorry, 70%. I'll just skip this. There is the last slide was the patients who are on this purified the EPA, and that is icosapent ethyl. These patients, when they were treated with this agent, caused a huge reduction in their cardiovascular events, and that was again due to the triglyceride lowering. But they also found out that the events rate, whether primary or secondary, were not only due in the high triglyceride, but across all the triglyceride ranges. So this is my last two home messages, that cholesterol plays a fundamental role in atherosclerotic cardiovascular disease. In many patients, cholesterol-containing LDL is important, but we also need to think about the triglyceride-rich lipoprotein, which is a part of our diabetic population. Triglyceride is a good marker for thinking about the triglyceride-rich protein, lipoprotein. If not, we can do simply the non-HDL, which is a good marker for all the particles which is hanging around in the blood. With this, I thank you all. Thank you.
Thank you, sir. Such an interesting topic, but obviously the time constraint. We have a question from Professor Khurshid. Sir.
First of all, congratulations for an excellent presentation. Really loved the pathophysiology part of your presentation. That was great. Because the debate as far as triglyceride causing cardiovascular disease has been many, many years old, rather decades old, I would say that. Association of high triglyceride with small dense LDL particles is there. We know this from metabolic syndrome, from diabetic dyslipidemia. But the bigger question is because earlier, back early 2000, there was so much enthusiasm regarding lowering triglyceride, trying to improve the cardiovascular event. And then the field study which came, that put a kind of damp on this whole thing, that fenofibrate did not improve the primary endpoints in these patients where we thought high triglyceride, if we bring it down, it may help. This study was primarily geared towards seeing how the fenofibrate will affect the cardiovascular outcome. Primary endpoint was not different. I realized a secondary endpoint, there was slight reduction in the non-fatal MI, and so my question to you is, because as one of the treating endocrinologists, I honestly, if my patient's LDL is in good control, usually I don't get much concerned with LDL, with triglyceride anywhere, I would say maybe less than 300. Yes, it goes above. I'm more worried about pancreatitis and other problems than cardiovascular disease. So I would like to get your take on this. How do you look at from your perspective?
That exactly was my topic to tell you, was that if you just coming back to the field study because of the time. Now the field study was diabetic population. They put patients on fenofibrate without any statins, but then there were patients then put on statins. So there was a bit of problem with the methodology or during the trial, because a lot of patients who were supposed to take the placebo, they went on statins. So there was a bit of methodology problem. Now, again, if you look at it, I put it there that their baseline triglyceride was only 1.7, which is around 160 milligram and so forth. Now, I didn't show you the slides, which I have got the slide. Even if you do the subgroup analysis of the field, exactly the same replica you get it, that the patients in this, this one, that if you pick out from the field study, patients who have got a high triglyceride above 200 with a low HDL, these are the patients who get the benefit to the percent, 31%. So it's a subgroup analysis, I agree with it. The whole question is, I'm talking about that triglyceride is a risk marker for something which is going on underneath. And that underneath is this VLDL remnants which is hanging around, because triglyceride, as I said, coming from VLDL particles. Now the question is, are these VLDL particles, which are manifesting itself as high triglyceride, are able to cause the atherosclerosis or not? I showed you in that the Mendelian, the nature's experiment, low triglyceride equals low atherosclerosis, and that is through the ApoB triglyceride rich lipoprotein. Your question is that when you see the triglycerides, you don't bother. Even in the guidelines now, they are saying, once the LDL you are happy with, and you have got the high triglyceride, then think of attacking it. Be it fenofibrate or isocop, the Vesepa, which is the new kid on the block, the purified EPA. So triglyceride is a marker for your underneath some kind of lipoprotein. But if you pick the right patient, which is the triglyceride just about 220, which is probably 2.3 or 2.4 millimole who are used to it, and with a low HDL, you are definitely going to get some. And this is from all the subgroup analysis of the fibrates. If you pick the right patients with a high triglyceride, low HDL, you are going to get the benefit. So my take is that, yes, it does need treatment after you have settled your LDL. And if you have still got some persistent kind of hypertriglyceridemia above the range of 200, think of either fenofibrate or the Vesepa, which is icosapent ethyl, which is the new kid on the block, which has shown consistently a huge reduction in the cardiovascular events in those patients. So things are moving. Thank you. Yeah, yeah.
Thank you, Dr. Khan, for a wonderful presentation. And so need to talk about this residual risk about the hypertriglyceridemias. And this new trial come about this reduced trial using this new kid on the block. And in a reduced trial, you're talking about this new kid on the block, and you use the purified EPA.
Yeah.
So far, if you look at the previous studies about this use of this omega-3, they didn't show any benefit in reduction in the cardiovascular events.
No.
I need your opinion. I need your
yeah, I
that.
slides, but because of this, I didn't show you. You know, the combination of the EPA and DHA, which is Omicron, I think, you know. The problem with this is that none of their studies have shown cardiovascular event, except in GCP, which was acute myocardial infarction, and they showed, you know, there was reduction. But they have got no concrete kind of cardiovascular event trial. They show all the time we have got the triglyceride reducing, but does it translate into cardiovascular outcome reduction? No. So far we haven't. So and in this reduce it actually, the juries is still out whether this reduction, which was amazing reduction, statistically they were extremely significant, whether it is due to the triglyceride lowering, because even across the low quintile of 130 milligram of triglyceride, they still got the same reduction in the cardiovascular. So they are thinking it may be antiplatelet, antithrombotic, some extra kind of, you know, oxidative stress, whatever. So probably this is a unique kind of EPA, which is purified and it's doing its job through some other mechanism other than reducing the triglyceride.
But if you look at the previous trial of comparing this EPA and the placebo has been used about the corn oil, which is like a more in a kind of inert oil. But if you look at this reduces trial, and they have used the placebo is not at the optimal level. They use probably mineral oil.
Yes, the mineral
oil. And that's causing some kind of inflammation. When you given an appropriate competitor as a placebo, you may have cut a results by chance even. What do you think about that?
You know, they corrected for all those kind of, you know, increase a bit of LDL due to mineral oil. They didn't find it. They couldn't find that reduction in the cardiovascular, you know, because of the mineral oil. They couldn't, even with this confounding factor, they took it out. And if you look at this purified EPA in Japanese study, they didn't use any mineral oil.
Yes.
So, and it still showed the same results, though it was open label. So the only criticism of the Japanese, it was open label. So juries is still out. But what I was interested to show with the fenofibrate was that we have got the two outcome trial. The one was the field one. The methodology in field one was a bit, you know, because the placebo arm where they should not be on any treatment, they were put on statins. They were statin in. So there was not a good comparison. But if you look at the subgroup analysis of the field, exactly the same thing, 220 your triglycerides up, this one, you get the reduction of almost 30% reduction or something like that. Field, the Eckhart lipid one, exactly the same. Overall result, nothing, because they started with a low median kind of, you know, triglyceride of 160. But if you do the subgroup analysis, separate the one with typical dyslipidemia, which I have been asking, then what we need is a good trial.
Exactly.
Diabetic patients or CVD patients with triglyceride of over 220 strictly, with HDL below, you know, 0.4 or something, and put them on those triglyceride lowering treatment or VLDL, you know, kind of, you know, lowering treatment. And then to show, I'm sure this kind of patients will be the one which will benefit from it.
Yeah. Thank you so much, Dr. Khan, for enlightening that. And then I take your point, Dr. Khurshid. You rightly said that it's a point of big debate about these triglycerides, and definitely we need a more robust data to be more focused on these things. Thank you so much.
In interest of time, can we move on with the next presentation, please? Thank you.
Moving forward, our next lecture will be Professor Dr. Ali Jawa. He is Medical Director, WILCARE. He's the past General Secretary, International Panel Physician Association. He's Adjunct Professor, UHS Lahore. He's President, Entrepreneur Organization, Lahore Chapter. He's ex-President, PES, ex-president, American Association of Clinical Endocrinologists, Pakistan chapter. He's diplomat, American Board of Internal Medicine and Endocrinology and Diabetes. He's diplomat, American Board of Physician Nutritional Specialties. He will be talking on fatty liver as an endocrine disease. Professor Dr. Ali Jawa.
Assalamu alaikum and good afternoon, evening, or a combination of both. Thank you everyone for being here, and I'm excited as ever to be present here. Pakistan Endocrine Society is very near and dear to me, and I'm very proud to be associated with it. I think at this time, the topic that I have, when I got it initially, I was a little worried that might be a little bit boring. Then when I started looking into it, read about it, I started thinking in a different way. So you have to bear with me that the trajectory I'm taking is unconventional, is unorthodox, and if it works, I'll be happy. If not, forgive me for that. The topic that I have is fatty liver as an endocrine disease. So that is something which intuitively that came to my mind, oh, that is a liver problem. That is something that a hepatologist should be looking into. That is something that we manage, but we don't own it. We own diabetes, we own metabolic syndrome, we own other conditions, thyroid, we will just embrace it full-heartedly. But fatty liver, maybe it's not ours. But being a doctor, at times, you tend to have a second thought. So where would I get the right answer? Whether it is a liver problem or is it an endocrine problem? This could be an existential question, a rhetorical question as well, or it could be a simple scientific question. The problem happens when, how can you remain unbiased? How can you remain very much, what do you call, objective? And the question was very much in my mind, whether it's an endocrine problem or is it a liver problem. So this is where the conundrum, where I was. So you can substitute mom with doc. And I'll tell you why I wrote mom here. While I was preparing for this lecture, I came across a WhatsApp, the perfect and the most absolute source of information in our part of the world. Everything that comes in the WhatsApp is proven to be correct. The doctor could be wrong. Everybody else in the world is wrong. But agar ye WhatsApp mein aa gaya hai, ye theek hai. So I got something like this that I hope this animation works. If it doesn't, that's my fault. I think it's not working. It is, all right. It was something like, it's very difficult to explain without this picture. It was a monologue that a mother saying, "Mera beta उठ गया, सेरी के time पे, and मेरा प्यारा बेटा उठ गया." और उसकी तस्वीर ऐसे कि जैसे उसके बाल उड़े हुए हैं, उसके मुंह की रंगत बदली, लेकिन माँ को बच्चा अभी भी प्यारा लगता है. So the fact is that we are very much driven and looking forward to getting an unbiased problem. If you can ask the mother to give you an unbiased opinion, then you have won. And that is what the thought process was. Because if the mother can say that the information that they're saying, the thoughts that they're saying, they are unbiased, then you have won. I came across a book called The Mom Test. Very interesting one. They say that if you ask a mom something, you need to know how to ask the question. If you ask the wrong question, you will not get the right answer. And that is where the issue is. Okay. Okay. The Mom Test is a 102 pages book. Basically, it is designed for you to be able to get the right answer from your customer. If your customer says something and you are able to elicit the right answer, then it works. So, सेरी के वक्त पे बच्चा उठता है तो माँ कहती है मेरा प्यारा बच्चा उठ गया और ये आपका प्यारा बच्चा है कि जो उसको उठा हुआ है, तो माँ को तो अपना बच्चा प्यारा ही लगता है. तो इसके लिए ये एक किसी ने एक छोटी सी किताब लिखी. I think this is a very apt book. How to ask the right questions. If your mom can answer it without any bias, then you have won. So the questions, I framed it in my mind as if I need to investigate this thing. Is it, what are the most common liver problems you find? What do you think is going on? What did you do about it? What did you find it? How did you fix it? Who did you ask to fix it? If you ask it like that, I think the answer will be unbiased. And incidentally, that translated to our typical way we do our presentations. Epidemiology, what is the common liver problem we find? Pathogenesis, workup, diagnosis, treatment, and referrals. So keeping this thing, I started that. 1980, Ludwig had first demonstrated or mentioned and published the article in which they had named non-alcoholic steatohepatitis, one of the manifestations of non-alcoholic fatty liver disease. And they had done biopsies, and they had characterized that there were necroinflammatory changes, more common in women, those who are obese, diabetes, gallstones, and thyroid disease. And that pretty much holds true. Obviously, the science has moved on, and we have gathered a lot more information, but we will talk about that. Just to give an idea about the terminology, non-alcoholic fatty liver disease is a big umbrella term in which anything that is associated with the fat accumulation in the liver is there, other than alcohol consumption. If there is no fatty changes on biopsy, it is NFL. If there are fatty changes, it is NASH. Secondary causes are what have been associated are I've listed here. So if you need to diagnose somebody who has NASH, they should not have a secondary cause that is there. These are the causes of diseases that can cause NASH. And if they are not, then it is idiopathic or cryptogenic. So fatty liver is the commonest disorder in the world. United States, the prevalence is as high as 10 to 46%. Worldwide, it is 6 to 35%, median being 20. And biopsy-based studies, as you can realize, you cannot diagnose NASH by an ultrasound. You cannot do it just by an ALT and AST. So biopsy-proven NASH incidence is 3 to 5% worldwide. It's complex. It's a combination of insulin resistance, fatty inflammatory liver changes, and involvement of the endocrine system. So it's a complex intertwined mechanism. The link is not very clear. Some people have tried to explain the link, and I will do my best to explain that what the experts have mentioned. The hypothesis is many hormones and cytokines function in metabolic and immune roles, and then they control the inflammation. A very good explanation is in this. I think I might have pressed the wrong button. Okay. So it's a double hit hypothesis. It's very interesting. The double hit hypothesis, the first time, at least when I read, was when we were talking about what predisposes people to get cancer. But this is the double hit hypothesis that's been proposed in this situation as well, that due to lifestyle, type 2 diabetes, obesity, there is insulin resistance, which leads to increased hepatic liver lipid production. And as a result, there is abnormal free fatty acid accumulation and the fat accumulation. And then there's a second hit, and which causes the further damage and which leads to further progression that ultimately leads to fibrosis. That makes a lot of sense. This is the Marino et al. Hypothesis that is being discussed. And if you look at it, the endocrine causes from top to bottom. Now, interestingly, you must have remembered Dr. Richard Quinton's talk, in which he was mentioning about hypogonadism. See, I will mention that in the future as well. Even central hypogonadotrophic hypogonadism does also contribute to insulin resistance and fatty liver. So starting from the hypothalamus, thyroid in the form of hypothyroidism, pancreas in the form of insulin resistance, decreased GLP levels, adrenal gland deficiency, and that's also very interesting. I'll explain that and expound that a little bit later on. Adipose tissue, when there is associated with decreased leptin and adiponectin, and gonadal system, in which there is decrease of the sex hormones. So in hypogonadism, both types of hypogonadism, whether it's hypogonadotrophic or hypogonadotrophic, are associated with increased risk of metabolic syndrome, which ultimately leads to fatty liver, 5 times risk. PCOS, very interesting. It is also associated with insulin resistance, and it's a bidirectional relationship. Whether it's a genetical predisposition that leads to them more susceptible to develop polycystic ovarian syndrome when there is the environment is right, or when there is environment there and they have a vulnerable underlying genetic makeup, they become that. So it's a bi-directional relationship. For hypothyroidism, and this is a very hot area of research these days, and if you look at their primarily animal studies in which they felt that the hyperphagia associated with hypothyroidism, along with the mitochondria becoming more energetically efficient, it leads to the development of insulin resistance. And this has been stipulated that it is associated with hypothyroidism, NASH, cirrhosis, and potentially liver cancer. Growth hormone deficiency has been also been associated with development of NASH. And DHE sulfate deficiency. Now, this is a very interesting thought. Deloria et al. As well as Charlson et al. Did postulate in 2 different studies that DHEA sulfate deficiency leads to the NASH and the possibility of development of further liver disease. Whereas in 2011, Koga et al. Had a counter article in the Archives of Internal Medicine in which they said that increased DHEA sulfate level leads to possibility of NASH. So this is something that needs to be watched because the correlation can be misleading at times, but these articles are there. I just mentioned it for academic interest. Adrenal insufficiency, that's an interesting aspect. They also postulate a bidirectional role, whether one has liver disease that leads to adrenal insufficiency or adrenal disease that leads to liver disease. And eventually the story is still out, but we will eventually learn that over the years. So now the question comes, when a mom asks, when a son asks the mom, "Mom, am I fat?" What is the mom gonna say? Mom is most likely to say, she always feels her son is emaciated. यार इतना सा मुंह निकल आया है, तुम तो खाते ही कुछ नहीं हो, तुम्हें हो क्या क्या है, तुम अपनी सेहत का ख्याल रखा करो, मैं तुम्हें कहती तो हूँ तुम खाना सही तरह खाया करो। और ये होगा जो बेटा जनाब पला पलाया होगा और मुंह इतना ज्यादा निकला होगा, फूला होगा. So you need to be very careful that what you ask the mother and what questions you ask. Now fatty liver is very serious problem, is the first case report of visual pathway defect from China that they can go blind. No, I'm kidding. Fatty liver doesn't do that. So it's fatty liver workup. As I said, in order for you to say that the person has NASH, you need to rule out secondary causes. And the secondary causes we had discussed is hypothyroidism, growth hormone deficiency, hypogonadism, polycystic ovarian syndrome, prediabetes and type 2 diabetes. So the workup that we should be doing should be these. In order for us to diagnose NASH, there is no perfect non-invasive test. I would say that again, even ultrasound, you may find the appearance of fatty liver, but that does not constitute NASH. Liver biopsy is the gold standard. Everything else is supporting it. The ultrasound, the blood test, and exclusion of other things, and the resolution, depending on the treatment, means that most likely it was NASH. And this is a diagnosis of exclusion. So how do you treat it? Now that's where the fun starts, because that's what we are being clinicians, that we are looking forward to. How can we treat it? There is no one silver bullet. There are multiple drugs that have multiple sided effect, which have an effect. Metformin is our favorite drug in Pakistan as well as worldwide. We will discuss that later on, but I would like to focus on the lifestyle modification. Weight loss superior or equal to 7% improves the liver histological findings. Now that is important because we traditionally ask people to lose 5 to 10% of the weight as part of type 2 diabetes management anyway. So as a result, we are not only treating their diabetes, but we are also improving their NASH. Diet and exercise improve weight loss, steatosis, and lobular inflammation. This is also makes a lot of sense. So this part of the spectrum is in line with how we're treating most of our metabolic conditions such as diabetes. Metformin, it does not improve histology. It does improve the overall diabetes control. It does improve insulin resistance, but 4 randomized controlled trials that were conducted did not demonstrate any effect on the progression of the non-alcoholic fatty liver disease. TZDs have a very strong data that is supportive of that, but the reason why TZDs are not first line is because of the side effect profile. As a result, we need to be very selective. But so far, they have the strongest data that has been published, even for troglodyrazone as well as rosiglitazone that has been published previously. Statins, atorvastatin has been studied, and the Hygo et al. Demonstrate that they improve the transaminase levels and the fatty liver. 4 people out of the 91 that were studied, they progressed to the fibrotic stage. Ezetimibe has data that suggests that it improves and has efficacy for the treatment of NASH. It was an open label study and it was a single study. So we cannot put too much into it, but there's some evidence to suggest that. 2 ARBs, the angiotensin receptor blockers, telmisartan and valsartan, have demonstrated that they do improve the liver histology and the transaminase levels. Vitamin E in the PIVENS trial, which was pioglitazone as well as vitamin E study, it was compared with the placebo. This was published and it showed significant improvement in the liver fat content, but not the fibrosis. The side effects of high dose of vitamin E was a limiting factor, and that is probably the reason we are not using it that frequently in our practice, because it has other effects, including increased triglyceride levels. Now, this has received a lot of attention and a lot of coverage. And these 3 studies, they were very rigorously conducted, very good, well designed. They were backed by biopsy proven data of the hepatic fat content, and their improvement was significant. The Silverman study was 65 out of 91 had resolution. In the Martin et al. Study, 90 people were biopsied before, and then they were biopsied afterwards. 16 had the same level of fat content, 25 had improved fat content, and 49, more than 50%, totally normalized their hepatic fat content on the second biopsy. The third was 109 patients with morbid obesity and histologically proven NASH. 1 year after bariatric surgery, NASH disappeared in 85% of the people. So this is an astounding result, more than any pharmacological study that have listed in the previous ones. They have not been able to demonstrate any benefit. So as part of the treatment, screening for the secondary causes still remains very important, because when you treat it, things improve. The underlying hepatic liver fat content and the progression improves, and this has been studied very rigorously. And lastly, if there is a problem, who does the patient get referred to? It gets referred to a hepatologist, which is somewhat unfortunate, because if the fatty liver is there, they are supposed to be treated by an endocrinologist. And I make the case here that there has to be a concerted effort to encourage the primary care physicians to consider us the first point of referral if they're not able to manage the fatty liver. Many of things we can educate them, and when they find into a trouble, they should do that. Take-home message are simple. It's a one of the commonest CLD, closely linked with various endocrine diseases. Genetics will give a much more clue who is more likely to respond. Additional studies are needed. As always, every part of talk has to have that. Many treatments are useful. Prevention is useful. And family physicians, GI, and endocrinologists work together. So what is the verdict? Is it an endocrine disease? Most definitely, maybe. The jury is still out. We need more studies. But the question is, mom or the doc is always right if you ask the right questions. Thank you very much.
Thank you so much, sir. Do we have any questions from the audience? Yes, please. Achha, we have 2 questions, sir.
based on the data you showed, everybody should be referred to bariatric surgeon.
It seems so. I think the more I've been seeing the data in the previous PES conferences as well, it seems like we are failing.
They are
The
claiming
surgeons are winning.
send everybody to us.
Mike,
Thank you very much. It's a very interesting topic. Actually, I think Dr. Jawa, it's actually, we call it a metabolic surgery. We have got a huge cohort of patients going for bariatric because in UAE, it's such a, kind of for cosmetic reason, for whatever reason. And believe it or not, I don't have the data yet, but we are looking into it. We have got almost a reversal of diabetes. And usually reversal, if you do it early, it causes the reversal of diabetes, all the liver enzymes and all this. The only thing which doesn't improve, which I tell the patients beforehand, is the lipid abnormality.
Yeah.
The weight go down and the lipids go the other way. I do not have the right, answer for this one, but that's why it's called metabolic surgery now, because you are correcting a lot of metabolic abnormalities, including the fatty liver and so forth. Talking to your, just the second one, quick one. If you look at the pathophysiology, the liver is being bombarded with free fat. So is there any data showing that poorly controlled diabetics versus the well-controlled diabetics with the same kind of, start with weight and so forth, the poorly controlled diabetics have progression of fatty to NASH quicker than the well-controlled?
I don't exactly remember I've come across that study. I'm talking on the reference, but there is data for that. Yeah.
So my name is Professor Sabahat Javid. I'm a histopathologist, to be precise.
Yeah.
So you have actually told in your slides that atorvastatin actually improves the transaminases,
yeah,
which is actually contradictory to my observation in the pathology laboratory.
Okay.
Atorvastatin mostly disrupts the transaminases. And second, I want to actually ask from you that if the patient is having the hypogonadism and leading to the NASH, so what sort of the treatment you actually suggest here?
Hypogonadism, the management we do, for the first question, I think instead of going, you have your observation, you have every right to have yours. I'm just quoting what the evidence-based data is. In most cases, if that's due to fatty liver, it does improve that. That is what I've seen many times. Second part is the question that you have about, can you repeat your question? Yeah. Hypogonadism, if it depends on the patient. If the patient is in the fertility range and they prefer to have their treatment according to preserve the spermatogenesis, then many a times, depending on the type. If it's a primary, we give testosterone replacement. If it's central, we may actually LH analogs would be useful as well. But as long as you are able to raise the testosterone, whatever the underlying cause is, whether it's hypogonadotrophic or hypergonadotrophic, it has the same benefits. The study that was presented by, if you look at the one by Richard Quinton, the first study that they talked today, it does demonstrate that there has been no conclusive evidence of increased of prostate cancer by giving testosterone replacement. There has been several studies that he quoted. I won't repeat that talk. It was a very comprehensive talk by Richard Quinton.
Can I make a request?
Professor Ali Jawa, can I ask about role of fibroscan as investigation in fatty liver NASH? Fibroscan.
Fibroscan. Okay. Fibroscan is a very useful tool. It is using the elastographic technique. It gives you an idea about the liver state. It is still very close to the non-invasive that you can imagine, but the gold standard is still liver biopsy. But again, liver biopsy is a very invasive procedure. Fibroscan is the closest you can come to a non-invasive test.
One last question and then we'll
just wanted to make a small comment. I really like the example which you gave of a mom. So I think the life of the mom is going to be simpler, easy, because gastroenterologists themselves, in 2020, they have coined the term the consensus has said that, instead of using the term NAFLD, they should use MEFLD, which is metabolic associated liver disease.
Yeah.
So now I think, this battle is going to end, that NAFLD or, non-alcoholic fatty liver disease belong to endocrinologist or gastroenterologist. So if we use the term MEFLD, that means, it is associated with the metabolic disorder or obesity or things like that.
I think it's a time to capture the market. We should gather our resources and be the gung-ho supporter of treatment of fatty liver.
Thank you, sir. We might not be able to take any other question. I'll request our worthy chairs for their final words, please.
Thank you, Neba. I think so. We are already running short of time. So just a quick, the very comprehensive, excellent talks by all these speakers. Dr. Richard Quinton has really elaborated the role of late-onset hypogonadism and its treatment. And the Dr. Niaz has really given, again, a very excellent talk on the diabetes and the hypertriglyceridemia. So both the talks were excellent. And for the next two talks, I will request Professor Khurshid Khan to comment on that.
Yeah, it has been an excellent opening session of Pakistan Endocrine Society's annual meeting. Great talk by Hamad Faruqi. I think the innovations are always helpful in uncertain situations. But like earlier, Dr. Khadija pointed out, you need to have more manpower, more resources, full support staff, maybe more nurse practitioners in your practice to take those, respond to those alerts around the clock. But I think an excellent app which can be consultants for telemedicine can work around that. That was a good presentation. Secondly, Dr. Ali Jawa, Professor Ali Jawa, we all know he's a good presenter, and non-alcoholic fatty liver disease or metabolic associated liver disease is not an easy topic to cover, because you look at this from upside down, downside up, left to right, right to left, it seems the same. What started that? Weight started that? Did NAFLD itself cause insulin resistance? So I think that was a very comprehensive talk, and it comes down to lifestyle management, weight loss, and topic very well covered. Thank you all very much for being part of this session. I guess there's okay, back to Dr. Niba. Thank you.
Thank you, sir. Now I'll request the President PES, Dr. Ibrar, to please come on the stage to give away the shields as a token of thanks. Firstly, for our worthy chairs, Professor Saeed A. Mahar. I'd like you to clap, please. Thank you. Professor Dr. Khurshid Khan. Dr. Niaz. Clap, people. And of course, Professor Ali Jawa. And I'll get mine as well.